I think we are already slightly running out of the schedule. Let me invite Dr. Amit for our next session, which is on evolution of TKIs treatment in ALK positive non-small cell lung cancer. And I'll also invite the panelist over here, Dr. Shailesh, Dr. Vamshi, Sujit, of course myself will be there. The previous session was sponsored by Roche. Sorry, I forgot to make a mention. Thank you.
Good afternoon, everyone. I think Sujit is not here. Dr. Guru Prasad would be taking place. So, Sujit. Good afternoon, everyone. So, thank you, Nikhil. Thank you, Vamshi, for having me here. So, we will quickly have a sort of a discussion about how ALK TKIs have evolved and what we do in clinical practice. So, we've seen how lung cancer molecularly has changed our practice, and the thing we become most happiest about in clinics are the day we see our patient comes in and we send the NGS report and it comes as ALK positive, or we do an IHC and we see ALK positive. I think among all the molecular markers, when we see an ALK report, we are the happiest. And probably what we talk to patients also is the outlook is so different compared to all the other molecular reports. And that's because of all the developments which have happened. We started with crizotinib many years back, then we had in the second generation, we had alectinib, and now we have lorlatinib, and we're getting better and better in treating these patients. Nikhil, we are here now, but we still have challenges, and what are challenges you think about when you see an ALK positive patient these days? How do you think about first-line challenges to your patient?
I must agree to the fact that when you say that we get excited, yes, we all of us probably get excited. But at the same time, at the back of our mind, there are certain challenges. And first and foremost remains, maybe after the initial lines of therapy, what's next? So one is definitely about the sequencing. I mean, that is something which we always talk a lot. In addition, the patient with the brain metastasis is something what we are now trying to understand. Although we are already making our inroads in that part, but still we have a long way to go. And as we already mentioned about the ALK resistance, which is really quite, I would say, holy grail for all of us, something what is always concerns us.
Right. So, Nikhil brought out all those points we talk about where we say, we know 30 to 40% patients of ALK will have brain metastasis at presentation, and that's something that we keep thinking in our minds. How will we treat them? Will we treat them differently? We know resistant mechanisms can come in, as Nikhil has said, and sequencing keeps in the back of our mind. Are we using the right sequence? And that's something we keep thinking about. And I think the biggest challenge today is what goes in our mind, what is our right first-line therapy we are doing? And how do you choose first-line therapy? And that's something very, very challenging in our thing. And I think we'll take this forward to discuss how what all of us do. But before we do that, let's quickly look at the data. The CROWN was the trial which was presented the last, where lorlatinib was compared with crizotinib. A good phase 3 trial, again showing a clear benefit in PFS with lorlatinib versus crizotinib, with a hazard of 0.28 in the overall population. We saw the 3-year data presented a couple of years back, and what we saw, even at 3 years, you had not reached the median PFS. Why this is important is because with alectinib, we had a median PFS of 36 months if you took the investigator assessment, and it had 25 months if you took the BICR. But again, we said 3 years is probably the median PFS. Here, at 3 years, you have not reached even the medians. You are at 63% versus 18%, hazard of 0.27. And we also saw the patients with brain and metastasis, with or without, your hazards are exactly the same, 0.21, 0.29, clearly telling you lorlatinib is a very effective drug in comparison to crizotinib. So these are the trials we have at first line. We have the CROWN data now. We have the LX data for us, which we have had for the last few years, where you compared alectinib with crizotinib. And again, you had a hazard of 0.5 and a very effective drug and also effective in the brain. And you have these cross-trial comparisons we do. We don't have brigatinib in India, so I think we can skip the ALTA data. We really don't need to discuss that. LX and CROWN. So, Vamshi, when you get a patient first line, how are you thinking about your first line therapy?
So,
I actually am pretty much convinced with the Crown data. So there was this discussion of sequencing, all that we used to have a couple of probably years back. I was thinking more. I think since last year, I'm more or less convinced that lorlatinib should be the first line. For me, the data is not just in the patients who have the brain mets. The better data, which I'm sure you're going to show later, is the one that in patients whom you're on lorlatinib, the brain failure is very, very low.
Yes.
And that really tips the scales for me. And if you took it in any other way, yes, you can argue that it was compared to crizo, it was not compared against alectinib, and all that is fine. But given the situation, I'm quite comfortable using lorlatinib as the first choice.
So you have shifted.
I have shifted. Unfortunately, I think a lot of my colleagues have not shifted because last 3 patients when I offered lorlatinib, they went and took a second opinion and got shifted to other drug. So that's what happened with my last 2 patients. But I counsel for lorlatinib.
You are also
I would counseling for lorlatinib.
Yeah, I think this is how the science is changing, the data is changing, and all our answers are changing. A couple of years ago, when we used to sit in meetings, all of us used to say alectinib first, sequencing thoughts. Now, some of us say lorlatinib first, not all of us, and I think all of us are correct because we have different thoughts in our minds, and I think that's the way the whole thought of treating patients better changes. Dr. Guru, what's your thought on this kind of data set? What do you think? Would you be shifting towards alectinib or lorlatinib for your patients?
As Vamshi said, lorlatinib, with the data available, lorlatinib, that's the first go-to drug for us.
Okay. Shailesh, have you shifted or you still are on the sequencing?
So I agree with Vamshi, and I also agree to the second part. 2 of my patients who had counseled about lorlatinib was shifted to others by someone else. So, but I myself try to convince regarding the data, and I'm myself convinced about the data for first line lorlatinib.
Right. Okay. So majority, we would say, and Nikhil, you're on lorlatinib first line or alectinib followed by lorlatinib?
So I use both, but I have kind of shifted my loyalty more towards lorlatinib in the recent times. But there are some patients who will still go for alectinib.
And we have patients on alectinib doing well for years. So it's not that alectinib is a bad drug. It's absolutely not that. It's just that the ALK space is so good that you have these multiple options.
So just a quick anecdote. The last patient I had was actually a patient with atrial flutter and fibrillation with a lot of cardiac issues, and he got this positive. And then we read up that, okay, lorla actually has an interaction, it causes junctional rhythm problem.
Okay.
So that's the patient I put on alectinib because it's a good drug. Like you said, there's nothing wrong about alectinib. It's not a bad drug at all. It's just that this data looks a little better.
Right.
That's all I think we can say.
Right. Absolutely. And I think Vamshi mentioned this. This is the time to intracranial progression, and this has been the amazing data which came out from the Crown data. You're saying, look at those hazards. For all patients trying to intracranial progression, the hazard is 0.08. Now, when they divided the patients who already had baseline metastasis, and if you gave lorlatinib, you have a hazard of 0.1. And patients who didn't have baseline mets, time to intracranial progression, that hazard is 0.02, and that's a hazard, We keep telling this is p-values. And that's why the first time when you see this, you think, oh, that's a p-value. And that's the hazard. So clearly telling how good the drug can work in preventing brain mets. And I think there's no doubt this data is really convincing about it. Again, that doesn't mean alectinib doesn't work in the brain. So suddenly what happens is the data of lorla is so good that one suddenly thinks, no, the other drugs don't work. We clearly say crizotinib doesn't work in the brain, so absolutely no crizotinib for patients. But alectinib does work in the brain, but lorla is even better. So, Nikhil, if you have a patient with brain mets who comes to you, what are your thoughts about cranial radiation these days? What do you do?
So we go by symptomatic versus asymptomatic. In a symptomatic probably patient, then probably I'll still offer the patient radiation. Asymptomatic patient, probably lorlatinib remains the first line recommendation for this.
I think this is what has been really changing in practice again very rapidly. We used to say whole brain radiation, then we said no whole brain radiation for everyone, just SRT to the brain, those lesions. And now we are coming to a stage where we say, if you have such good drugs penetrating the brain, why radiate? And I would stretch and say, even for symptomatic patients now, we are not radiating the brain. Even symptomatic patients, I say, the drug is so good, we are tempted to say, why do it?
So I'm not courageous enough till now, but it might be, probably the experience probably would decide. But for now, I think for all symptomatic, I do irradiate the patient.
So my thought keeps coming to, we have these few patients now in long-term follow-up, whom we are seeing patients with radio necrosis of the brain, And in ALK, if I see a radionecrosis, I know these patients can go on to 7 years, 8 years, 10 years. You keep worrying, why do it? That's the whole thought. So we have actually, in our practice, changed, and we are not giving radiation to the brain, even to symptomatic patients. We're starting the drug immediately and telling, let's evaluate quickly in few weeks. And if you're okay in few weeks and you're feeling better and the scan is okay, we'll avoid it if possible. Vamshi, your thoughts?
I completely agree with that. The only challenge is getting the report on time. Again, these are practical challenges. My NGS will take 2 weeks to come. If patient is very symptomatic, again, if there's only 1 or 2 lesions, I'm okay, because I would just actually send them for surgery, not even doing a radiation at that point, because we know that surgery is faster. But very symptomatic, I would give steroids. If it's responding very well, I would still wait for my NGS. And again, we know that the patients who have brain mets are likely to have a mutation. That's the other side of the picture.
Absolutely.
So I think you should discuss in an MDT and convince your radiation colleagues that, look, this works. I think that's the only way to really push for it, and that's what we are doing.
Right. I think really it's changing the way our outlook is completely changed. Okay, let's move to toxicities. Dr. Guru Prasad, experiences lorlatinib toxicities and alectinib toxicities. What has been your experience?
The hyperglycemia part, we usually start with 1 HbA1c at week 2, and then again week 4. We ask them to come back at 1 month, 2 months. We see the hyperglycemia HbA1c part. Triglyceridemia, as you already told, it's slides explain everything almost there. So I don't think I need to explain in great detail. But these are the 2 common things, because in India as a diabetic capital, we do this more commonly. All others, we...
Right. Okay. So hypertriglyceridemia, that's been the major one. And subsequently, we have talked about edema, weight gain. And we talk of these CNS cognitive disturbances. Dr. Sailesh, have you had experiences with toxicities and any of these kind of toxicities which we talk about?
So I think peripheral neuropathy is something which I have not come across too much. However, the cognitive effects is another reason why you should not start with radiation for this patient. So I keep that in mind, because if the patient is already radiated and came to me with the report, then I'm a little skeptical, whether to start alectinib or lorlatinib.
Right. And hypertriglyceridemia has been a problem?
That's quite often seen.
Yeah,
that's...
Correct. So that's one thing, hypertriglyceridemia is very common. We really say it will happen in majority patients, not to worry about it, just put them on some rosuvastatin. Yes, sir.
So neurocognitive issues with lorlatinib are much more common than is described in the studies. And I have one elderly lady who's just able to tolerate 25 milligrams of lorlatinib. So I think that is a big concern.
Yes, sir. Agreed. So this is the differentiating factor between trying to use alectinib and trying to use lorlatinib. The CNS side effects are something that we didn't know about. And this is something that we learned with time. In the initial studies, we saw it was only 20-30%. But when the newer studies, the newer analysis, real-world experiences, it's all coming down to 50% of patients can have disturbances. And what we are learning is we should talk to our relatives. We should not talk to the patient itself. Of course, patient we need to talk to, but we need to talk to the family members about, are they seeing some changes in cognition, changes in mood, changes in behavior, which can be very mild, or disturbance in memory, and there may be mild changes which are there. And this is something different with lorlatinib. But again, most of our experiences have been it is quite manageable. Dose reduction is what has to be done if you're really having toxicity, and that's something you need to be careful about. I think, Nikhil, your experience in terms of these toxicities?
So again, the main toxicity which probably we all should be cognizant about is neurotoxicity, neurocognitive dysfunction. I had one patient who came to us through one phase 4 trial, and it was a hard time for us when it was initially started. But over a period of time, probably we have learned how to adjust the doses. Many times the patients are slightly old. I don't go for the full dose. Maybe I start with a slightly lesser dose and then go on. But if it happens, it really happens. And then many times you may not be able to re-challenge that drug ever for that patient. So there are few cases which are there. Absolutely. For us also, we couldn't really challenge one patient.
Right, absolutely. I think point well made. Dose reduction is required in many patients when you do lorlatinib. And Nikhil brought this up, that sometimes we actually reduce the dose and start at a lower dose. And it's actually not wrong to do it if you're an elderly patient, if you have a patient who's little sick, starting with 75 mg rather than just starting at full dose 100 mg. When we didn't know it initially, we were trying to push in 100 mg, but now we're not doing that any longer. And we say if patients are fit and fine, 100 is fine. But some of these patients, we can actually start with 75. And the good thing is now you have analysis like these, which show that if you do 75 or do a dose reduction also, there's really no loss in the PFS and your patients are still doing well. So again, I think this should be something that we are adapting to and learning. The other side of it is alectinib has been really very well tolerated, and I don't think we've had major side effects with alectinib. Vamsi, you have had side effects with alectinib in practice? Yeah, I think.
I mean, you get some diarrhea, you get occasional side effects with both of the drugs. So it's not really a case of, again, like we said in the beginning, it's not a case that one is a bad drug. It's just that two good drugs are there, one is probably better than the other.
Right.
And like I said, if we are not able to use Lorla or if you're having a side effect, we are happy to switch to alectinib.
Right.
It's not that we don't have choices. Oh, we have 3 minutes.
Right. So perfect. I think. Let's quickly a couple of questions. Do you see variant analysis? Do you really bother about variants?
Yes,
You
should.
You do.
You have, because
And
I got a patient who was treated somewhere else, and the person called me for a second opinion and said, "Look, I have given alectinib, and within 3 months it has progressed. How is that possible?" Then we looked at the report. It was saying very clearly it's a variant 3.
Right.
Which is where you know that the other drugs are not very effective.
Right.
So you need to look at it.
So we have data, but I don't think we have guidelines to say we'll use a variant to choose the drug. So we don't do that, but we know Lorla probably works in both, in the variant 1 and 3, where alectinib has a little bit less response in variant 3. But this is all retrospective analysis, so I don't think we really go absolutely choosing the drug by that. Shailesh, progression, what do you do? ALK positive patients, biopsy, NGS?
So, as a dictum, I convince for a rebiopsy for all my lung patients who progress on a targeted treatment. So, for ALK, no difference. You have to do a biopsy or do a liquid biopsy, whichever is possible, or do both if it is possible.
Right. So resistant patterns. When you're treating ALK, what is your main concern? G1202R is our major concern, and we know Lorla is the drug which works for G1202R. But we have seen that if you treat with the first generation, you actually hardly develop G1202R. But if you treat with the second generation, the chances become much, much higher. And that's the reason why we always say Lorla has been the only drug which overcomes G1202R. Nikhil, if you treated with second generation, do you just go to Lorla? Or if you treat with Lorla, what do you go to?
So you are asking a question about post-alectinib and going for
So
subsequent
suppose you started
lines.
with alectinib.
Yeah, of course. We again try for NGS whenever it is possible. G1202R is something what we are looking at. But anyway, lorlatinib being a pan-ALK inhibitor, that anyway is the go-to drug for most of us.
Right. So that's why when we say if we are going to Lorla, we actually may not get too much information from the NGS. We may as well just try Lorla. But if it moves from a first generation to if you are going to alectinib, then we definitely need to see for the G1202.
But you also might get sometimes some complex mutations, so we can get better prognostications for the patient. So that can add.
So this was the data where they actually looked at it that if you treated Lorla, you don't develop ALK mutations, and that's why they said that's why we want to use it upfront. We are going to prevent complex mutations from developing. But what we are learning, if you treat with ALK, with Lorla first line, you may develop bypass pathways, and bypass pathways become dominant then. But again, we learn how to do this better, I think. So I think let's quickly finish off with last minute, right? Okay. Vamshi, Lorla is your patient on progresses. What do you do?
So again, I think we'll do the NGS. We'll see what else is an option on NGS. Otherwise, we would possibly go with the chemotherapy at that point of time. Later on, again, you can re-challenge. I mean, that's how I would go about it. And I don't think it's such a bad option at all.
So one thought is, if you had a patient on Lorla who progresses and the brain is doing well, what do you do with the Lorla? Do you stop it or do you continue it?
So again, depends. It's an oligoprogression. I would go ahead with just local treatment. That is something we are all comfortable with as of now.
And if it's a full-fledged progression?
Full-fledged progression without progression of the brain, I would go with chemo. I would reduce the burden and then go back to either Lorla or use some other TKI at that point. But yes, re-challenge with ALK will be an option.
Right. Okay. So we're learning this a lot, and even when we used to talk about osimertinib in EGFRs, that if we gave osimertinib and when we didn't have the newer options, when patients progressed, if they didn't progress in the brain, we added chemo, but we kept the osimertinib gain, saying we are protecting the brain. Now, we are having the same conversations now with Lorla, though the trial didn't do it this way, but we start having this conversation. If the brain didn't progress, would you want to still continue protecting the brain and continue chemo? But then the dilemma will become that Lorla will not stop. It will keep happening, going on and on, because it will keep protecting the brain. So it's a very interesting space, and I think whatever said and done, we are improving survival for ALK-positive patients. It's very heartening. We have seen patients surviving now. From the clinical trials, the medians have reached 8 years and longer, and I think that's the best survival in the molecular-driven cancers. So thank you very much, and thank you everyone for this. Thank you.